Welcome. Good evening and welcome. I would like to welcome you on behalf of the EANS CSF section and on behalf of the EANS spine section. I would like to apologize Florian Ringel, who would also like to welcome you. He is currently, I think, still busy in the OR probably. And we have a special webinar today. We have a topic that affects probably both sections. This is why we joined. And we have a distinguished speaker, Marcel Ivanov, who will talk about spinal cord herniation. And I briefly introduced Marcel. Marcel is a consultant neurosurgeon and spinal surgeon, and he is his main NHS practice is based in the UK, in Sheffield. And he's a fellow of the Royal College of Surgeons from England, and the honorary senior lecturer at Sheffield. He has the spinal lead at the Department of Neurosurgery and Neurosciences, is the director of AO Spine Center in Sheffield, and he's also the chair of the AO Spine UK and Ireland since a couple of years. And he was trained all over the world, in the States, in Germany, in Finland, in Belgium, in Japan, and of course in the UK. He has several awards, and his main interests are spinal pathologists and this is why he is here today, with a focus on minimally invasive neurosurgical techniques, and is involved in a myriad of other EANS sections, committees, and training courses. So he's well known and a brilliant speaker with a brilliant topic. So I'm very honored to introduce you. And now, Marcel, the stage is yours. And please let me remind you one more, put your questions in the Q&A section, and I will read the questions afterwards, and we will have plenty of time for discussions. So Marcel, and please all enjoy.
Jürgen, thank you very much. Thank you very much for this very kind introduction. And I think the main question is why we are discussing today about this entity, spinal cord herniation. Yeah, because if you look into the literature, it is always described as something very rare, something very unusual. So why we are studying this, and why we're discussing about this particular one and not about microdiscectomy? And I think there is a very important reason for this. I think the main reason is that although it is described as a very rare entity, I don't think that it is so rare. I think it is much more common than we've been taught. And I think main reasons why this is rare is that there is a very low degree of awareness about this condition. So the main purpose of this webinar, which is jointly done by the spinal section and CSF section, is to raise the awareness about this condition, which is frequently underdiagnosed. Frequently, these patients are going between doctor and doctor for many years before having this diagnosis and before having the treatment. These are my disclosure, which are not related to this webinar. And what I would like to cover within next probably half an hour is, first of all, some general information about thoracic spinal cord herniation. We'll discuss about the differential diagnosis with other conditions, which is quite commonly to mistake with other conditions, in particular arachnoid cyst. So we'll focus on this a little bit. We'll discuss about the clinical picture, and I'll pay more attention on the management and on the surgical strategy of this kind of conditions. Obviously, we'll discuss about the challenges. So spinal cord, as we all know, is a very delicate structure. Anything related, any condition, any pathology related to spinal cord is a delicate one, potentially high risk if something goes wrong. So we'll focus on challenges and the ways to resolve it. And we'll have a couple of cases, which I hope will be a good demonstration about what to expect when we have this condition, which is described as rare, but I don't think it is so rare. So what is spinal cord herniation? Spinal cord herniation is a condition where basically the spinal cord herniates through a ventral defect or through a dural defect, because it not always is ventral. And subsequently, the spinal cord becomes incarcerated into this defect. It becomes strangulated. This strangulation affects the blood supply to this part of the spinal cord, to all the tracts, and subsequently the patient becomes symptomatic with myelopathy, which is often progressively deteriorating over months or years. before patients become myelopathic, I think a degree of symptoms which we'll need to be aware of is patients which have symptoms of CSF leak, of low intracranial pressure. So that's something which we'll touch in a minute. The condition is not new. It has been described 60 years ago, so we can celebrate now 60 years anniversary. It has been described as incidence of 0.05, 0.08, but again, I think it is much more common. If you look into the literature in PubMed 10 years ago, I believe only 15 cases have been reported. If you go now, then there are more than 300 papers describing the spinal cord herniation. For some reason, it is more common in women, nearly twice more common in women comparing to men. And again, what is more important is that this condition, despite being present and described, it is frequently misdiagnosed or not diagnosed for many years before having some treatment. So this, as I said, if you go on PubMed and put the keyword in the title as spinal cord herniation, you'll get 322 papers. And I must say, I really had good time over the last week to go through some of these relevant papers. You can see many of them have been published in 2023, 2024. So good reading. So I would really, good to dive into something like this. Now, pathophysiology, why this is developing. And I think the first answer is there is no clear pathophysiology. There are several theories, but there is no clear mechanism why this is happening in the age group of 40, 45, 50, why this is happening in women. But the main theories is, first of all, is congenital theory, where we believe that there was some meningeal malformation or dystrophism, or the dura is congenitally narrow initially, which becomes thinner over the years, and then at some point spinal cord herniates through this defect. The other theory is that this is acquired. So basically what is postulated is that the patients may have some microtrauma, repetitive microtrauma to the dura. Sometimes there could be some erosion of the dura via some disc osteophyte. And in many cases, we will see some disc osteophyte which erodes, makes this dura thinner. And at some point, the spinal cord or the CSF will leak through this defect, and then it will attract the spinal cord. So we should remember that in the thoracic spine, we have some degree of negative pressure, and we have the positive pressure of the CSF from inside the dural sac. So basically, spinal cord goes through this defect. But why we have this dural defect, it is not always clear. Some people postulated that this is an inflammatory condition, and we can have, we've seen several cases of iatrogenic spinal cord herniation, which I think we'll show a couple of cases later. So basically, what is happening, for some reason, the dura becomes thin. For some reason, there is a defect in this dura, which is getting enlarged over time. And through this defect, initially the CSF comes out, and patients may develop some low pressure headaches. And subsequently, this hole becomes plugged by a spinal cord, which gets strangulated, and the patients become symptomatic from myelopathy, which is progressively deteriorating over time. Again, one of theories which has been described is that, some documented, is that, as we all know, the dura, in particular in the cervical spine and in the thoracic spine, it has two layers. So you have the internal layer and you have the external layer. So initially what is happening, you have a small hole in the internal layer of the dura, and then the CSF goes into this and displays, kind of squeeze between the internal and external layers, and then subsequently the spinal cord will go into the same space. As I mentioned, before having features of spinal cord suffering, we have situations when patients may have symptoms of intracranial low pressure, yes, so hypotension. So these papers look into into their patients. So a third of the patients would have extradural fluid, which can be detected on the scans. Yeah, so that's something we can see, and often we see some extradural fluid which we don't recognize. We don't know where is it coming from. So that could be the initial early stage of potential spinal cord herniation, which the patient may develop later. So this is just a quick description of how this happens. So it's a small dural tear, and then the CSF leaks between the internal and external layers, and then subsequently the hole gets blocked by the spinal cord, and patient becomes myelopathic. Distribution of the spinal cord herniation, very interestingly, it has been described only in thoracic spine. It is getting more common over the peak of the scoliosis, of the kyphosis of this thoracic spine. So in T4, T5, T6, this is where most of the spinal cord herniation will occur. But as I said, initially, it is not always ventral. We had several cases published in the literature where the spinal cord herniates laterally. So this is a very interesting case where the spinal cord just goes laterally. Not clear why this happened, but it has been well described with a good treatment, good outcome after surgery. And sometimes you have a spinal cord which herniates posteriorly. So this is a spinal cord which was herniating through the posterior dural defect, eroding, going into the lamina. So again, very interesting, very unusual, difficult to explain mechanism, but things like this may happen. So it's not only ventral as we initially thought. Now, clinical presentation, as I mentioned initially, first of all, patients may have some low pressure headaches, very unspecific. Yeah, nobody will think that there is a spinal condition. And then subsequently, patients may have insidious onset and progression of symptoms of pain. If you have the dural defect and then you have some nerve root incarcerated into the dural defect, they may have some radicular pain, intercostal pain. If it is more lateral, so anterolateral position, patients frequently will have this Brown-Séquard syndrome, which may happen in up to 65% of cases, which were reported in the literature. And in later stages, if not treated, the patients will develop this paraparesis, spastic paraparesis, and in very advanced stages, they may have sphincter problems when the spinal cord is suffering, like any patient with a spinal condition. Again, I will repeat again, these symptoms are often missed. These patients will go through various professionals before having a scan of the whole spine, which will show this potential spinal cord herniation. The MRI scan is frequently pathognomonic if it is in advanced stages. So you can see you have this buckling of the spinal cord, which is going through the dural defect and touching the vertebra anteriorly. Usually have this sharp angulation or kinking of the spinal cord. But what we always have to consider that there is a differential diagnosis with the arachnoid cyst. Arachnoid cyst, or arachnoid web, which may frequently give a very similar picture. This is what it looks like in case of spinal cord herniation. But in arachnoid cyst, I mean, first of all, the clinical picture has been described that it could be slightly different comparing to spinal cord herniation. This paper looked at the potential differential diagnosis between these two conditions. So in spinal cord herniation, it is more significant. Usually the neurological deficit is more significant, and you're more likely to have a Brown-Séquard syndrome, and the spinal cord looks kinked on the scan. But this is the picture of arachnoid cyst. So again, spinal cord looks displaced. There is this bayonet appearance of the spinal cord. There is some signal change within the spinal cord. And you would think that, okay, let's do the myelo-CT. And with the myelo-CT, you should be able to see whether there is any contrast going into the arachnoid cyst. And you would assume that if it is arachnoid cyst, that it will not be filled with the contrast, but that's not always the case. So this is one of such scenario. You have a patient which on this we had a question whether this is arachnoid cyst or spinal cord herniation. Myelo-CT didn't show any filling defect, but it was arachnoid cyst. This is a case which we had last week. Actually, we were really convinced that this patient likely has spinal cord herniation. So the reasonably young lady who had this progressive deficit in the lower limbs, previously had several surgeries in the lumbar spine, but symptoms have deteriorated. So eventually she had an MRI scan which showed this kind of kinking of the spinal cord with some signal change distally. I wasn't convinced whether this is arachnoid cyst or a spinal cord herniation. So we've done the myelo-CT. It didn't show any filling defects. So okay, the radiologist convinced me, okay, this is probably a spinal cord herniation. So we got our knife sharpened with my colleague, Ramez Ibrahim, who is, we do lots of these cases together. And what happened is before opening the dura, I've done the ultrasound, and on the ultrasound, it was much more obvious that this is actually a very typical arachnoid cyst. So we didn't need to scrap two surgeons. So it was a much quicker surgery. You open the dura and divide these membranes. Now, as I said, we have this condition not so uncommon. The question is, should we operate them all, or do we need to consider this only in some specific cases? And usually we need to consider this when we have a picture of progressive myelopathy. Obviously, if you have incidental finding, it's better sit tight, but you need to explain to the patient what kind of symptoms to expect, and if there is something changing in future, they should be aware about where to come and what to do. But our usual standard indication in Sheffield here is when you have a patient which has progressive or severe neurological deficit, which is getting worse over time. The goals of surgery are several. First of all, we want to release the herniated spinal cord from this dural defect to make it free. And we want to try to prevent reherniation of this spinal cord into this dural defect. And there are several ways of dealing with this, and I'll try to cover this in the next few slides. So previously, there were some attempts to do a direct dural closure with the stitches. I do find it not so straightforward. You have a big defect, and it is a hazardous procedure. It's in a narrow space in front of the spinal cord, and it will never be watertight. That's a big defect, which will be very difficult to simply restitch, close it with a stitch. Other options is to place a dural graft between the spinal cord and the dural defect. Other options which have been described is to enlarge this dural defect, so the spinal cord will not get herniated into this cavity, will not be strangulated. At this stage, there is no consensus, so I think within the EANS, we are looking to get some consensus from the community, what would be the expected standards of practice in these kind of conditions, which are not so common. So several options which have been described, which I mentioned. One is to have repair, restitching of this dural defect, not straightforward, not easy. Risk is quite considerable. The other option is to fill this defect with some fat, or to fill it with some other material like collagen or other, I don't know, other grafts in front of the spinal cord to prevent reherniation of the spinal cord. That's another paper which looked into the options of repairing it. So once you remove the spinal cord from this herniation, you can place some something to prevent the spinal cord falling back into this cavity. So the authors used the piece of fat, and the other option is to, in addition to this piece of fat, to put additional layer of artificial dura around the spinal cord to prevent this reherniating. And this is what we do actually in Sheffield, but without the piece of fat. So this is a patient who is 56, again, progressive paraparesis for 3 years. So many patients, usually they, if there is a myelopathy patient, they will do an MRI scan of the cervical spine, which was unremarkable. But on examination, all these positive long tract signs, brisk reflexes, clonus. So the MRI scans show this spinal cord herniation, which is quite typical appearance. So there was no doubt about this. When we prepare the surgery, we normally don't need a lot of equipment, but microscope is a must. We do it with the intraoperative monitoring, which I think is very important, because one of the steps of the surgery is manipulation of the spinal cord. We want to detach the dentate ligament, rotate the spinal cord, and we want to make sure that by this maneuver, we are not causing any harm to the patient. So if there is any drop of motor evoked potential, then we will relax, we will increase the blood pressure. So it gives us some guidance about how aggressive we are, or the reassurance that whatever we are doing is safe. So as steps, we have the microscope, intraoperative monitoring, some simple dissection instruments. I like this suction, which you can adjust, so teardrop suction, which you can adjust the power of the suction by closing the hole partially or fully. And the steps are basically laminectomy, laminotomy. Usually what I'll do, I'll cut it with the craniotome, pediatric craniotome, remove the lamina and block, and at the end of the surgery, we can reposition it back to restore the anatomy. Second is durotomy, which is midline, posterior, and then you have the slices of the dentate ligament to allow us to rotate the spinal cord and release its attachment from the herniation. And this is the short intraoperative video. So again, we do these cases with two consultants which have a good pair of hands. So it's, first of all, it is increasing the exposure to this condition, which it describes to be rare, and it is good to have an understanding and kind of fine skills. So what we have is spinal cord herniating into this dural defect. We release, sometimes it is very stuck, sometimes it is very loose. So in this case, you push the dura away, and after dividing the dentate ligament, as we do now, we do rotate the spinal cord. It gives us enough room. In the thoracic spine, usually have quite a large spinal canal. So enlargement of this dural defect, as you can see, it will not be easy to restitch it, repair it by stitching this big defect. So in our case, we place this additional layer of artificial dura in front of the spinal cord and just extract it from the other side, mainly to allow us or to prevent the spinal cord to fall into this cavity. And this cavity, in our case, we filled with a collagen matrix, so just to have something to push this dural defect and hopefully to reduce the risk of CSF leak. So once we place this additional layer of the artificial dura around the spinal cord, we make sure that it is touching the dura, so there is no additional space between, and basically we close it in one stitch. So you can see like 4 layers of dura. One is the real dura, the other one is artificial, which goes around the spinal cord and prevents the spinal cord from falling into this cavity. And once this is closed, obviously we want to make sure that there is no CSF leak. We'll put some various options. We have various options for this. And normally I will try to reposition, restore the anatomy, but by putting these laminars back with some mini plates and reattach the muscles, which I believe is beneficial. This is the ultrasound appearance. Yeah, so this is what it looks like on the ultrasound once you place this artificial dura, so the spinal cord doesn't fall into this cavity. The postoperative MRI scan, usually it shows that this restoration of the normal spinal cord alignment. It may not be immediate, but we usually do it by default with the next couple of days to see what it looks like after the surgery. So this is pre and post-op MRI scan. Now, what would be the outcome after this kind of surgery? There are not so many papers. So what we don't have randomized control studies. We have several meta-analyses. The biggest meta-analysis looked, I believe, at 128 patients. And the generated outcome from this is that approximately 75% would have some improvement of the symptoms after this kind of surgery. 18% may not have any improvement. They'll be exactly the same with ongoing symptoms. 70% will have some permanent new deficit after the surgery. And this is what is important to discuss with the patients and explain that, look, there is a risk. There is a risk because we have to manipulate the spinal cord. 7%, 1 in 15 patients may have some new permanent deficit. And improvement doesn't mean that they will be back to normal. Improvement means that 70% of patients will be better than before the surgery after some time. It will not be immediate improvement and it will not be back to normal. So that's important to discuss with the patients at the time of consenting. Now, we should be aware of potential some short-term and long-term complications. So short-term complications obviously is the CSF leak, is the infection, spinal instability, I mean, lots of things which may happen. But we may have some specific long-term complications, and for these long-term complications we have the risk of retethering. Sorry, there's somebody ringing at my door. And then we have the risk of developing some arachnoiditis and the risk of having CSF leak, pseudomeningocele, low pressure headache. So that's something which we will need to be aware of and to have an option to repair these kind of things if necessary. Now, we discussed about the options of having a patch. We are using artificial dura, but there are several other options which are available. You can use fascia, you can use fat to fill this gap within the spinal cord, within the dural defect to prevent the spinal cord falling into this cavity. We have various dural substitutes, Teflon, bovine pericardium. All these options are available. I don't think there is a gold standard. I think a lot depends on what you have in your own department available. One of the questions which we should always ask is, what is it an option not to operate? What will happen? What is the natural history of this condition? And again, what we don't have is we don't have a randomized control study. We don't have a study which will compare randomly patients that had surgery and patients that didn't have surgery. The only paper I could find is this one which looked at, I believe, 18 patients, 16 or 18 patients. Half of them had surgery, half of them didn't have surgery. But those who, what is important to understand is that those who had surgery this was at the discretion of the surgeon, and 100% of those who had surgery were clearly myelopathic, while those who did not have surgery, they were not myelopathic, symptoms were mild. So if you combine and look at the long-term outcome, there is not big difference. But again, this is not a randomized trial. The outcome should be very carefully interpreted. So it's not an option in my opinion, it is not an option not to treat surgically if patient is clearly deteriorating over time with deterioration of myelopathy. We want to prevent this, and we have a surgical option to do this. Now, a few words about iatrogenic spinal cord herniation. Sometimes this happens, and I've seen one case, but there are few cases published in the literature. This is a patient, again, known with NF, neurofibromatosis. There was a tumor located anterior to the spinal cord, operated, tumor excised, no problems, spinal cord well decompressed. This is the MRI scan 3 months after the surgery, no concerns, but we normally follow these patients up on yearly basis, even if it is NF, in particular if it is NF, because there is a risk of recurrence. So these patients contacted me telling, look, I have some new problems, recurrence of symptoms in the arms, reduced proprioception, some new balance problems. So my first thought, this is probably another neurofibroma. So let's do a scan. And it was a surprise to see this kind of appearance. So despite repairing the dura, probably it was not a complete repair. So the patient developed this spinal cord herniation, which pushed us to go back and try to repair the defect. So luckily, this pseudomeningocele was a helpful one. So it helped us to get to the spinal cord without causing any damage, without unnecessary manipulation. So what we've done, we just opened. This is all previous T-seal, Duracell, artificial dura, which we tried to enlarge to release the herniation of the spinal cord. And I'll quickly go through this. So basically, we enlarged it and created another layer of the dura to allow the spinal cord to fall into this cavity. So this is the post-op MRI scan. Patient didn't come back, so that was, we had few follow-ups, no further issues. So in conclusion, what I would like to mention is that although it has been described, spinal cord herniation has been described as a rare condition, it is not so rare. I think this year only I saw 5 patients just in Sheffield, and I presume there are much more in other units, and it will be good to have some more collective data, and EANS is really a good forum to combine this kind of information, maybe to create some registry of these rare conditions. So what is important to understand is that this diagnosis is frequently delayed because of low awareness, but I trust all of you who are part of this webinar will have a special eye to see if you have a patient which doesn't have answers for the symptoms of myelopathy, just to look carefully at the thoracic spinal cord and make sure that there is no spinal cord herniation or arachnoid cyst. Surgery is a good option. It can help to improve the symptoms in more than 70% of cases, but we should consider this only when the patients are symptomatic or progressive symptoms, and surgical repair is usually the gold standard. I don't think there is any other option to repair the spinal cord herniation, so we should consider this, but the patient should be aware about the risks. 7-8% of patients may develop some new deficit, which could be permanent for the rest of the life. Thank you very much.
Marcel, this was brilliant. Thank you very much for your focused, concise, and talk with the beautiful images and beautiful surgical videos. So just please now put in your questions in the Q&A box, and I might probably start the discussion with the key question, Marcel. It is, of course, I completely agree, it is not so rare. It's not so rare as you think. We should be more aware of it just by brilliant talks like yours, and we should really look for it, and we should see when the spinal cord deviates to the ventral side, most often at the thoracic spine, and look for the symptoms, because most of these patients have a very long history. So, but the key question is to operate or not to operate, and when to operate. You elegantly put it, operate in symptomatic patients. and or patients with a severe deficit. But to be honest, almost all patients are at least mildly symptomatic. So does this mean you operate all your patients, or do you follow some of them conservatively?
Yes, I think it's excellent. A really good question. And this is what should be, in my opinion, not necessarily the surgeon's decision. This should be a discussion with the patient. So normally we should have a formal discussion and tell them, look, you have a condition which is likely to be responsible for the symptoms you described, which at this stage are mild, but there is a risk that these symptoms may deteriorate over time. What we don't know is whether you will be one of these patients which will have this deterioration, or you may stay as you are now for a long time. And we have few options. Option one is, let's watch and see. We can do another scan eventually at some point in a year maybe, or we can do another scan if you feel that something is changing. And this is what normally I will tell my patients. I would not rush unless there is a significant or clear history of rapid deficit. When you have mild symptoms, I give both options. Initially, I keep an eye on this, and we have few patients which are not progressive. I mean, they can do it like this for years. And why would you risk being exposed to all the risks of surgery if your symptoms are stationary, non-progressive, you're walking miles, you don't have any deficit, you might have some dysesthesia, but yeah, so this is a discussion, and somebody will be more keen to go ahead with surgery. They will accept the risk, in which case I am the one who will do my best to avoid these risks, but we cannot guarantee that this kind of surgery are without risks. So yeah, to summarize, if we have a patient with significant symptoms, I would strongly recommend surgery. If the finding is incidental finding, the patient may have some scan for a different reason, and you can have some kinking of the spinal cord, I would like to see this patient to do the detailed neurological assessment, to look for some hidden symptoms which the patient may not be aware, to look for reflexes, check the plantars, see if there is any clonus, and explain the symptoms to the patient. So if a patient may not have anything right now, but they need to know what to expect, when to be worried. Yeah. So if they become some legs giving way, balance is not as good, then this is the sign. Okay, we have an open appointment policy. The patient will call my secretary, will see this patient, and then we'll discuss about what can be done. It will be highly unusual to have an acute deterioration. So I don't remember seeing a patient who would deteriorate within weeks, but I had one patient who had an episode of deterioration which has improved. So that happened after straining. The patient lifted some heavy luggage, putting in the airplane, and that prompted the sensation of legs giving way. So she went to the on-call team, had a scan didn't show anything new, and eventually she improved, and then had surgery after that. Initially she was declining the surgery, by the way. So yes, I think the key point, we discussed this with the patient. We'll inform the patient about both options. My recommendation is to consider surgery if it is clear myelopathy, but we have the option of watch and see if symptoms are minimal or non-existent.
Excellent and very well balanced. But on the other hand, I think it's important to tell, don't lose these patients. You need to reschedule them, because I think there are more and more reports. And I remember one report from, I think, Isabel Hostetler. She also wrote up a couple of patients where surgery ended up in a better outcome than this conservative treatment. And to be honest, there's no rapid decline, but I've personally never seen a patient that was symptomatic that really improved. And they all kind of stepwise, at least in my experience, deteriorate. So there's a very wise decision by you not to rush them into surgery, but most of them, if not all, will end up with surgery, because when they are in this process of stepwise getting worse, I think it's even more difficult to get them back to normal. What do you think?
I agree when you have, in particular, when you have a clear spinal cord herniation. Yeah. So when you have this questionable arachnoid cyst versus spinal cord herniation, that's the case when I will sit tight. But when you have a clear herniation, this is not going to go back to normal. Never. This is not going to reposition itself. There is ongoing problem. This defect is going to be there or it may get larger. So that's what we need to tell the patient,
Okay.
but sometimes we are not so sure about arachnoid cyst and spinal cord herniation. In those cases, I would be cautious about.
Okay, then we are on the same page. In the clear spinal cord herniation, they probably all end up with surgery rather sooner than later. Not rush them the same night or the next week, but probably schedule them for early surgery. Excellent. Okay. I might open the round from the webinar. So excellent webinar, excellent webinar. Thank you very much. And there is one question. Congenital cases, question mark. Have you seen them in children, Marcel?
Personally, I haven't seen this in children, but congenital cases, this is something, it's a debate whether this is a genuine problem or not. And what I've seen over the last week, when I dig deep into the literature, several cases which were reported to be congenital, actually, they noticed that for a patient who had scanned for a different reason, for example, had it over the 10 years, and on many years there was no problem, and eventually the patient developed this condition later on, but it was some soft tissue problem. I think it was Marfan syndrome or one of these conditions. But the point is that we don't know what is the pathogenesis. I haven't seen this in children. Most of the patients in the literature, they're in the age group 40, 50, 60. And quite a lot of papers showing that patients potentially had scanned for different reasons, which didn't show any problem, eventually developed this spinal cord herniation later on. The reason is not clear. And again, sometimes it is osteophyte, but we don't, in many cases, we don't see any osteophyte there. So it's very strange. Maybe you have an answer, because you're quite a lot in this as well. So what are your thoughts about this?
Oh, thanks for the question. I have a very strong opinion on that, and I think these are all acquired. And in the cases where you have this double layer, I think it's quite clear at the moment that in the presence of a CSF leak, and they all have a CSF leak because there's a rent in the dural defect, there is a new membrane formation. So from my perspective, it's quite clear it's a acquired lesion. And you often see that these ventral spurs dissolve over time on its own. So the reason is gone, but you still have the defect. But I cannot prove this, and the case is not closed. But thanks. I haven't seen it in children. I have a very good question from Rob Groen. Regarding the operative results, it seems that you are quite optimistic. However, those data are from the literature, which unfortunately is biased by single case reports of successful cases with very short follow-up. Our own experience, and thanks for that question, is that results are less favorable, especially when following up for a longer period of time. For example, late development of syringomyelia, and what is your experience with that? Good question.
Yes, very good question. I think absolutely, I completely agree. We don't have a reliable information about the outcomes. 70, 68, 70 is the outcome from multiple papers, and they're very biased. I think we would definitely benefit from a registry, I don't know, European registry of this rare condition, to have a follow-up, to have a baseline assessment and long-term. But these numbers which I presented, this is the best we have. This is the best we have from meta-analysis. This is not kind of careful watching of these patients. Now, syringomyelia, well, I haven't seen it, I must say, but this is a recognized potential complication in patients with spinal cord injury. Yeah? So my main worry with these conditions is first of all, the arachnoiditis is in particular when we place this additional layer of material which is not patient's material. Yeah, so you have some artificial dura, and the spinal cord is continuously rubbing against this material with the pulsation. And I've seen a patient who developed some new edema in the spinal cord later on, years after this surgery. Clinically remains well, but there is some new edema. We've done another scan. There is no potential reason for this, but my main worry is arachnoiditis, which potentially could be related to syrinx as well. Maybe the edema is the first stage of arachnoiditis, which, of syringomyelia, which the patient may develop. So yes, there are lots of concerns, and this is one of my main one, is that this foreign material, and in particular when the spine is kyphotic, spinal cord is leaning against this vertebral body, and you have this artificial material, and this ongoing pulsation and rubbing against material is my main concern over long term. So we don't have any reliable data about what will happen in 10 years to these patients or 20 years.
So if you don't have long-term sequelae, what is the best material to use if you have such a good broad experience? What kind of foreign material do you use, not getting late onset syringomyelia?
Well, I use what I have, but again, I looked into the literature for this, and the best thing which has been described is to use fascia, maybe patients own fascia. I didn't use it. I don't have any experience, but I accept that this is an option. What I'm kind of more inclined to do, which is to try to, in some papers, some authors presented this as thin layer of fat which you place anterior to the through the dural defect, anterior to the dura, and put some glue on top of this, which will basically prevent the spinal cord herniating into this, and it prevents the CSF leak. And a good colleague of mine, David Choi from London, his option, which he described, which I really liked, is he is, whilst dividing the dentate ligament, he reinserting this dentate ligament much more superficial, so it holds the spinal cord, preventing this to fall into the cavity. So it sounds very elegant option. When I tried it, I had some difficulties because the dentate ligament was very, very thin, so I could not restitch it back to the dura, more kind of more superficial. But it is an option. I don't think there is a gold standard for this, and again, we need to look into this, have some joint collaborative work to find what is expected treatment and standards and some outcome for these patients.
Good idea. Another good question by Uwe Kehler. You do only midline approaches. Isn't it advisable to do a more lateral approach just to reduce the manipulation on the myelin? Of course, also with cutting of the dentate.
Yeah, I do a midline approach, and I don't see any concerns with cutting the dentate ligament. I do the midline approach because we have, if I put this artificial dura, we have to go from both sides, and I want to release the spinal cord attachment from both sides of this hole. If it is, if it is very lateral insertion, very lateral dural defect, then potentially you may consider it more lateral, but I think usually midline is enough. If I go laterally, I don't really want to compromise stability of the spine. I don't want to remove unnecessary the pedicle, the facet joint. So in most of the cases, it was sufficient. I really didn't feel the need to go more laterally. And sometimes we have these other conditions like anterior located meningiomas, and again, lots of debate about whether approaching it laterally or posteriorly, and it does work. Usually in thoracic spine, you have enough room, and I didn't feel the need to go more lateral to sacrifice that.
Okay, but as I get it, and I think personally as well, it's very important to approach, if you have a real herniation, that you approach it from both sides, because you never know whether the other side is stuck, and there's a risk of pulling or pushing too much on the spinal cord, and then you have a new deficit. So sometimes you need to cut out the dura on one side. So it's, I think, important to approach it from both sides, from the midline. Okay. Then a question from Pierre Mukuitala. Thank you very much for the presentation. The hernia only affects the spinal cord or even the root too. What to do if there is a root hernia accompanying the spinal cord hernia?
Yes, well, in some cases, I have seen the root going into this defect. Usually it is at that level, you have some motor branch of the nerve root. It is normally not stuck, so it's not always as initially my first concern when I did the case is it going to be stuck? How am I going to dissect the spinal cord? In most of the cases, you have a clear kind of dissection plan, easy to come, and usually nerve root will come out. Even if you have to sacrifice this nerve root, it will be a thoracic nerve root. It will not be a big deal. But I never felt a need to sacrifice this nerve root because it usually comes together with the spinal cord away from this dural defect, and you reconstruct the additional layer of the dura, and then nerve root is free. But if you have to, well, it's a thoracic one. The only thing we need to be aware of, if, for example, if you have a motor nerve root, and if it is T10, for example, or T9, this is the nerve root which goes to the abdomen. So patients may develop abdominal hernia. Because I had a patient for a different reason, which developed exactly this aesthetic problem. She was very unhappy about this. So,
Okay.
but it was not a thoracic spinal cord herniation. It was a tumor.
Okay. Another question by Jitendra Thakur. Is the spinal cord herniation pathology also position dependent?
Honest answer, I don't know. What we know is that most of these patients are ventrally located. I don't think that position will improve or deteriorate the symptoms particularly, but I would accept that with the straining, with the coughing, with lifting something heavy, the spinal cord may herniate more significantly to this, and this potentially may lead to some flare-up of the symptoms at that specific moment. Well, I don't know. What do you think about this, Jürgen?
No, I think it's once you have a full-blown spinal cord herniation, there is no position dependence anymore. It might only be in the beginning, but at least I don't experience.
It doesn't come back. Yeah, I don't think it goes back.
Yeah. Then a good and important question by Sakiba Jadon. How do you radiologically distinguish between herniation and adhesions/cysts causing ventral displacement of the port? So you showed a lot of good cases, that this discrimination is probably difficult. What is a arachnoid cyst? What is a arachnoid web? And what is spinal cord herniation on imaging?
Okay. I think the pathognomonic for spinal cord herniation is this kinking of the spinal cord. Yeah, so you have a loop which goes anteriorly. In arachnoid cyst or membranes, usually anterior part of the spinal cord looks in continuation, but it is posterior buckling, so like a bayonet sign. I can come back to my presentation if it helps and bring back this slide, which was very helpful to demonstrate. So this is the, I'll share it now. I think it's a good question. So it's important people to have answers to all the questions. So this is arachnoid cyst, which again is different to difficult, not easy to diagnose. You have the spinal cord, you have some signal change within this, but the main indentation is posterior, while anterior there is some degree of continuity. Yeah, and you would assume that, okay, you will do a myelo-CT. That was my assumption initially. You'll do a myelo-CT, and the contrast will not go into the arachnoid cyst immediately, so you'll have some feeling defect. But it was myelo-CT which looked like this, so it kind of. But the bayonet sign is usually a sign of arachnoid cyst, while for spinal cord herniation we have this kinking of the spinal cord. Yeah, so you can see this very much displaced anteriorly, so like a tummy which is protruding anteriorly. So that will be very pathognomonic for spinal cord herniation. But I must admit, we had a couple of cases where we really felt strongly that this is a spinal cord herniation. And when we opened there, we had this, it was arachnoid cyst, and this is the one which I showed with this ultrasound. That was very helpful to distinguish. That was it here. Yeah, so this looks very much like, I mean, a radiologist told us this is a spinal cord herniation. Clinical picture was a spinal cord herniation, but ultrasound was so helpful before opening the dura. It is much better than the MRI scan, much better than myelo-CT, where you can see very clearly this membrane, the pulsation, so that was a tool, but obviously you cannot do ultrasound before taking the bone out. So the patient, you'll have this information only when patient is having surgery.
Excellent. And I again agree. Sometimes you can only discriminate cysts from spinal cord herniation at surgery because MRI is not good enough to really discriminate it. Yeah, very nice picture. And ultrasound was a beautiful image. Good. Stefan Motov asks, what would you recommend in a patient with postoperative deterioration? Steroids, wait and watch?
Well, I have my feeling about studies. So I do find, Stefan, thank you very much. Very, very good question. So this is the question which usually people will ask for any intraoperative injury to the spinal cord. The same if you do it for myelopathy, for example, for ACDF or laminectomy, if you have some new deterioration, is steroid helpful? In my opinion, one dose intraoperatively of steroids, potentially, this is what will be done by anesthetist. I particularly don't feel that this is of much benefit. I do find it helpful if you have deterioration after spinal cord tumor surgery. So that helps to reduce the cytotoxic edema to the spinal cord. But the edema from the injury to the spinal cord, I don't think this is going to be of much benefit from steroids. But I'm not sure there is any strong evidence against or towards it. So yeah, it's probably the management of the spinal cord injury. That's the question. And we had few trials for a different condition of steroids, and the consensus is that risk of complication with steroids for spinal cord injury probably outweighed the benefit.
Okay, good. And another question, a follow-up question by Rob Groen. Would your fear for secondary arachnoiditis not be a plea for widening of the dura defect and not using any material to close the dura defect?
Yeah, I think arachnoiditis is one of the challenges we are all worried about. Yeah, and not many options. I don't think, again, there is any gold standard about how to manage this. But if you have a patient which is clearly deteriorating, then that's the option I would consider. Yeah, go back, try to divide, try to see if you can remove any material which could be causative for arachnoiditis, and find another way to repair it. Yeah, so potentially instead of having this artificial dura, try to remove it and put some fat into this defect and put some glue on top of this, or various options to consider. But again, arachnoiditis is really not a pleasant condition. I don't think, even if you divide all these membranes, if you had a clear arachnoiditis, it often comes back. Yeah, so you do it, looks good next month, in 2 months time, and then next year it will be again kind of going back to the same as it was a few years ago. And yeah, challenging. I don't think there is a clear answer. I don't know if you have, Jürgen, anything, any special tricks for this.
No special tricks, but fully agree with you that we need registries, probably within the EANS, for these conditions that are so interesting that we can do a lot of as surgeons, like spinal cord herniation and also arachnoiditis. And this is also the reason we should join for these specific diseases, our sections, to gather more patients. I think these questions are not solved yet. And I agree, good questions, and I don't have a special technique. I don't use the materials that are more sticky. I try to use inert materials, but I don't have a clear favorite. May I ask you another question? What actually is, you used it as synonyms. What is the difference, if there is any, between an arachnoid cyst and an arachnoid web? Is there a difference?
I don't think so. I think in arachnoid cyst it is much better defined. Yeah, so you have the arachnoid cyst. So arachnoiditis often comes as a result of infection. For example, patient had some infection previously, then it will be very diffuse all around the spinal cord, all around the spinal canal. So that's what I see as arachnoiditis. But we frequently have just a very well defined one single room cavity, which is pulsating and compressing the spinal cord, which usually you dissect, remove, and problem is sorted. I think the same origin, the same condition, but different representation potentially.
Good. One more question. Can symptomatic, by a non-named question, can symptomatic vertebral hemangiomas cause a herniation due, for example, the on and off of swelling of blood vessels? Have you seen that?
I haven't seen this actually.
Me neither.
I don't think there is a clear explanation, but I haven't seen this related to hemangiomas. No, I mean, there are potential theories, and I've seen a lot of literature, but I don't think it was described as hemangioma being one of the potential etiological factors. I don't remember anything like this.
You clearly described that you take this kind of surgery seriously, and you use, or you are to consultant neurosurgeons. Why is that?
Very good question. I think for all rare conditions which potentially are high risk, we need to have a good pair of hands. We need to have a people who understand what to expect. So usually it is not a solo, it's a duet. Usually you need to have 4 pairs of hands. So somebody will be gently retracting the spinal cord, somebody dividing, somebody will be looking, holding the suction. So 2 hands are difficult. I think that's my ex-boss used to tell me that the dream of neurosurgeon is to have 3 hands. I think 4 is better. So that's one reason. The first reason is safety. Second is the exposure to this condition, rare condition. If you do it just on your own, you'll see maybe 2 cases a year. If you do it with your colleague, then you will see twice more. And then sharing the load, sharing the experience is very helpful.
Thanks, excellent. Radek Frick, a good lecture. Do you have any experience with transthoracic approaches? Here in Oslo, we have operated 5 patients with this approach. Transthoracic.
Yeah, I haven't seen. I can see potential benefit, but I can see also the challenges. Personally, I haven't done it. I do transthoracic approach usually for calcified disc herniation, but even for this one, we've done several cases via posterior approach, transdural approach, and I was actually impressed by the some cases do really well with much less risk. So I think I think it is an option. The benefit of this would be to have a direct access to the dural defect, which potentially, if you have enough room, you potentially may consider restitching it directly without the risk of manipulating the spinal cord, without the risk of causing some new damage. So that would be the main benefit. But thoracic surgery comes with additional risks. MIS, where you avoid deflation of the lung, would be probably challenging for me, at least in my hands, to repair this dural defect through a very small hole with long distance. That could be a challenge, but I would be really interested to see the experience about the transthoracic approach. I think it will be a good one to share the experience with everybody else. Lots of benefits, but I think lots of risk as well.
Okay, excellent. So probably the bottom line is that we really do need to recognize this disease. It's a delicate disease. As far as I got it from your words, surgery is the option, the treatment of choice, and this is my experience as well. Don't rush patients. It's a shared decision making because surgery is not without risks. Take it seriously. Take another experienced surgeon. So, and then it's a good way to help our patients with spinal cord herniation and recognize the differentials and recognize the disease. Huh? Marcel, any final words for closing? This was a superb lecture and superb videos, and we are all through the questions now. Do you have any final comment or any recommendation? Despite probably we should focus our efforts in building up a registry.
Yes, completely agree, Jürgen. First of all, thank you for organizing this event. I think this is a very important topic, and I'm very grateful to all participants. We had more than 100 participants who decided to join this and not do anything else on this beautiful day. At least in the UK, it's one of the sunny days. So it's very important to see so many enthusiasts who were willing to get some more details about this condition, which is not so rare. The main message, we want to all get more aware about this condition. We want to learn that this is a surgically treatable condition. And what will be important is to establish some collaboration, probably international or European, to get this more data on this condition, because at this stage, it is only 300 papers, but all of them usually with some very limited number of cases. There is no randomized trials. There is no good outcome. There is no registry looking at the natural history of this condition. So I think this is the next step. And probably we should start some, at least collaborative program to invite people who are dealing with this condition to explain their attitude. Learning that this is done transthoraically will be also helpful information. So various options, if you know the outcome, if you know the complications, will help the next generation to choose what is best for the patients, which will continue to come to us.
This was an excellent closing word of an excellent lecture, Marcel. Thank you so much. And hopefully we continue the the joint forces of the CSF section and the spinal section, and we can establish a registry or some kind of working together. Thank you so much for this beautiful lecture, and all to the lovely discussions and the excellent questions. Thank you all, and bye-bye, and yeah, have a nice evening.
Bye-bye. Thank you for joining. Bye-bye now.
Thanks, Marcel. Perfect.